Over the last decade, our understanding of SCAD has evolved significantly. We know by definition that SCAD is a non-traumatic, non-iatrogenic, non-atherosclerotic cause of acute coronary syndrome. Historically, it was considered rare, but contemporary studies suggest SCAD accounts for about 1 to 4% of all acute coronary syndrome presentations. The increased awareness, the improvement in the diagnostic techniques have helped us to recognize that SCAD is more common than previously believed, and especially in younger women presenting with myocardial infarction. But what do we currently know about SCAD? Several important epidemiologic and clinical observations have emerged from the SCAD registries. First, we know that SCAD patients, the majority of SCAD patients are women, typically between their mid-40s and early 50s, although SCAD can occur across a very wide range of age. Second, we know that the cause appears to be multifactorial. Many patients report emotional or physical stress before the event. Emotional stressors are particularly common in women, while intense physical stressors are reported more often in men. We also know that SCAD patients usually have fewer traditional cardiovascular risk factors, for example, diabetes, hypertension, or dyslipidemia, compared with patients with atherosclerotic myocardial infarction. And we also know that one of the strongest associated conditions is fibromuscular dysplasia, which is identified in a large proportion of patients. We also know that SCAD is strongly associated with pregnancy, especially during the postpartum period, and in pregnancy, SCAD in the setting of pregnancy has more severe presentation, high risk features, and is associated with greater chance of having a cardiovascular adverse event. And finally, we know that genetics likely play a role. Our current evidence suggests that SCAD is predominantly polygenic. This slide in some ways summarizes the current conceptual model for SCAD pathogenesis. The three-hit model proposes that SCAD results from the convergence of a susceptible vessel, which may include fibromuscular dysplasia or a connective tissue disorder or genetic predisposition, a predisposing condition such as hormonal influences like pregnancy, for example, and then an acute trigger, such as intense emotional stress, physical exertion, or a sudden hemodynamic surge that may precipitate the event. Two pathophysiological mechanisms have been proposed. The first is the inside-out hypothesis, where an intimal tear allows blood to enter the vessel wall and create a false lumen. And the second, and currently more favored mechanism, is the outside-in hypothesis, where bleeding within the vessel wall forms an intramural hematoma that compresses the true lumen. So, regardless of the initiating mechanism, the result will be coronary flow limitation and myocardial ischemia. But beyond the mechanism, what is probably more important is to first suspect SCAD, because the clinical presentation of SCAD often resembles a traditional acute coronary syndrome. With chest pain, with troponin elevation, with ischemic electrocardiographic changes. However, the phenotype of the patient should raise suspicion. Typical clues include a young or middle-aged woman with few traditional cardiovascular risk factors under hormonal influences and associated and with or without associated arteriopathies, such as, for example, FMD or fibromuscular dysplasia or Ehlers-Danlos, and sometimes with a recent emotional or physical stressor. SCAD, as I said, more often present as an acute coronary syndrome with myocardial infarction, but some patients can also present with ventricular arrhythmias with cardiogenic shock or even with sudden cardiac arrest. Because many clinicians still associate myocardial infarction primarily with atherosclerosis, diagnosis may be delayed if SCAD is not considered. So awareness is essential to avoid missed diagnosis. And once we suspect SCAD, the coronary angiography remains the primary diagnostic tool for SCAD. And according to the angiographic appearance, we can have 3 types of SCAD. The type 1 demonstrated the classic double lumen appearance, but it's more common to have the type 2 with the angiographic appearance that is characterized by long, smooth, diffuse narrowing. And we can have also a type 3 SCAD that can mimic focal atherosclerotic disease and may be diagnostically challenging. And in these cases of diagnostic uncertainty, intracoronary imaging with IBUS or OCT may help to confirm the diagnosis. This slide highlights the major differences between SCAD and atherosclerotic acute coronary syndrome. In SCAD, as I said, the mechanism is intramural hematoma formation with compression of the true lumen. And in contrast, atherosclerotic acute coronary syndrome is caused by a plaque rupture or erosion leading to thrombotic occlusion. And this is in atherosclerotic acute coronary syndrome, the thrombus is the hallmark feature. While in SCAD, the thrombus is usually absent or limited to the true lumen. The patient demographics also differ significantly. As I said, SCAD predominantly affects younger women with a few traditional cardiovascular risk factors. And also the angiographic appearance is different, except in the type 3 that is like, sometimes it's similar to the atherosclerotic disease. And why does the distinction matter? Because the strategies differ between the traditional acute coronary syndrome and SCAD, the medical therapy differs, the prognosis and the recurrence differ, and also the follow-up and the counseling to our patients also will differ. SCAD is usually managed conservatively because SCAD lesions often heal spontaneously, and the revascularization in the setting of SCAD can propagate the dissection or cause the intramural hematoma. So revascularization is not probably the preferred strategy in patients with that they are stable. Some standard acute coronary syndrome therapies may not help or may even be harmful in SCAD. And when I am talking about medical therapy, anticoagulation, thrombolysis, and prolonged dual antiplatelet therapy will require careful reconsideration once SCAD is diagnosed. The survival is usually good in SCAD, but recurrence can occur and may involve a different coronary artery. And what is important in the follow-up, we need to evaluate for extracoronary arteriopathy. We need to discuss with the patients the recurrence, the pregnancy planning, the exercise, and the cardiac rehabilitation. And also, we need to discuss mental health. I'm not talking about this, but the point is the practical principle in SCAD regarding the acute management. The procedural goal is clinical stability and an adequate coronary flow, meaning if the patient is stable, we will prefer a conservative therapy instead of revascularization. And what is probably more important is the post-SCAD care, because we will need to do some screening or some testing for evaluation of fibromuscular dysplasia. We need to review the medications, because aspirin and beta blockers are commonly considered, but dual antiplatelet therapy, as I said before, it's not like the standard treatment. We need to discuss with the patients cardiac rehabilitation. We need to discuss the physical activity that they can do and they cannot do after an SCAD event. And we need to counsel the patients about pregnancy, reproductive planning, about mental health symptoms, and we need to, of course, individualize the care. So in summary, we need to say that SCAD is a distinct non-atherosclerotic vascular disorder. The recognition depends on the clinical phenotype and the angiographic pattern, and the management and the follow-up differ completely from the atherosclerotic acute coronary syndrome. We opt for conservative care when the patient is stable. We need to assess for extracoronary vascular affection. We need to counsel the patients about the recurrence, and we need to individualize the treatment according to the patient. Thank you so much.